We're delighted to welcome you all this evening to the lecture with Dr. Martin Bollard. What do we know about our most vulnerable members of society? Lessons from people with learning disabilities. My name is Nikki Gandhi and I'm a member of staff at the University Centre, Telford. We're part of the University of Wolverhampton and are based in the heart of Telford in Shropshire. We would normally hold our public lecture programme in our centre in Telford, but because of the current pandemic, we have moved our lectures online. Before I introduce Martin formally and hand over to him, I just wanted to explain that there will be an opportunity to ask questions at the end of the lecture via the Q&A button. If you're using a laptop or a desktop, this icon is at the bottom of your screen in the middle. If you're using a mobile, it will be at the top right-hand corner. The lecture has been recorded, so please can I ask that you do not share any personal information in the Q&A. Dr. Martin Bollard is an academic practitioner currently employed as Head of Nursing at the University of Wolverhampton. Martin has worked with and researched alongside people with learning disabilities for over 30 years. As a learning disability nurse, he has held various practice leadership roles in the National Health Service. Martin was first nurse in the UK to devise and implement the annual health check in the 1990s. He has been a National Forum member for the RCN, a co-opted member for RCGP, and the former president of the Intellectual Disability section at the Royal Society of Medicine. Martin has published his work in peer-reviewed journals and edited 2 academic texts on learning disability. He has held different senior academic roles at 3 different universities. His current research work is underpinned by inclusive approaches such as participatory design methodology. This work adopts solution-focused look at health and safety and social care challenges. Welcome, Martin.
Thank you very much, Nikki, and a good welcome to everybody. It's glad to have people listening there on this Thursday, quite cold evening. So I'm going to talk maybe for about 30, 35, 40 minutes, and then really keen to sort of open it up to questions. So when I sat down and thought about what I wanted to share for this talk, I briefly considered going down what perhaps might be perceived as a traditional academic route, representing and setting a context with some data, reviewing some of the literature, and then giving some profound take-home messages by way of a conclusion. But then I thought, what is it I really want to share about my understanding and reflections of working with and researching with people with learning disabilities over my career to date? And it came down to three phrases really, or themes that can help us understand why this group of people are perceived as vulnerable and different, and these present the shape to the talk. So through the lens of learning disability, I want us to consider how society, just move through through society, we understand difference, value in listening to others perceived as different, and how we would celebrate difference. So my perspective is just one perspective and one voice. By way of sharing my insights and stories, I hope to set up the next public talk where we can hear through the stories of people with learning disabilities themselves who can share their own contribution to society in their own words. And in doing so, by the end of both talks, we will be able to have a collective sense check on this topic together and where we feel we are at this moment in time with our understanding of one of our most vulnerable population groups. I am also hoping while it's worth continuing to celebrate the value and diversity in people who may be labelled as categorised as different. And perhaps those listening to the talk today, I think my colleague Lynn Westwood, who's very good on the twitting, we may be able to continue this conversation because there'll be a gap between this one and the next one. So it'll be great if this perhaps launches and generates discussion that we can follow on to that social media format. So this then is the first of 2 public talks. For this one, I've decided to share a timeline initially through pictures, visuals, supported by narrative and case examples, whilst at the same time offering my own reflections on them. So let's take our first visual reference point. So this visual reference depicts the long stay institution, the hangover of the Victorian era, where people considered different and defective for many different reasons at the time, were warehoused out of sight in large faceless buildings. You may be able to see across the picture the word workhouse, which has been selected, showing that those with a broad spectrum of disabilities, inclusive of those with intellectual impairments, were not seen as physically functional in the labour market of the industrial time. So their contribution would be best put to work away from society. And I'm sure, well, as we share and think about your own thoughts and what that picture represents, it's also important to say the majority of people with learning disabilities live with their families, as a population group have always been part of our community. The second point I'd like to share is that the majority of causes of a learning disability are unknown. So to understand difference, it is first we need to recognise that difference has always been around us. But for me, we move through different transitions of tolerance and acceptance of difference over time. Like other social divisions within our society, gender, race, we move through these periods of tolerance. And being a great cricket lover, it saddens me, and I'm sure a lot of people, to hear the testimony last week from Azim Rafiq, the former Yorkshire cricketer, of the institutional racism he experienced, and he believes is endemic within English cricket. And for those not familiar with that story, and more familiar with maybe taking the knee, sorry for another sporting reference there, probably ask, how far have we actually come with our tolerance of race? So let's just bring it back to disability and taking our timeline, moving from the Victorian era and moving us to 1969. So this picture takes us to 1969, shows the shutdown entrance to the Ely Hospital in Cardiff. Now, for us in the field, the Ely Inquiry of '69 is really important. First printed in the Nurse News of the World, it drew a spotlight onto the abuse and discrimination against people with learning disabilities, and sadly began a long line of investigations providing shocking material evidence still being reported on today. Many of us will know Death by Indifference, the Winterbourne reports, and a couple of years ago, the BBC Panorama programme revealing the scandal at Walton Hall. So my own reflections, being socially orientated into the world of learning disability from the 1980s, beginning with my mum actually, who was an instructor in what at the time were referred to as adult training centres, day centres run by the local authority at the time, to then being trained in what was classed as a mental handicap hospital in Birmingham, and like many at the time, witnessed some horrific treatment of people. These hospitals were a community of people overseen and categorised by psychiatrists and nurses in a world of containment, and as we reflect through our contemporary lens now, viewed as block dehumanising treatment. But it was not all doom and gloom at that time, because as a result of the Better Services for the Mentally Handicapped White Paper in 1971, recommended the move to community care. And this triggered the resettlement programme for those living in this type of hospital setting. At this time, on completing my nurse training, I reflect back on helping resettle a gentleman back to where his family lived. He had spent 28 years in this environment in a long-stay hospital. And although we felt we had worked with him and gradually supported him with a good care package close to his brother, for the first 18 months after him leaving hospital, he still went back to the Friday disco where he saw his friends and what had been his community of safety for a significant part of his life. My learning looking back on this time was it was a time where the language and terminology used to classify this group marked out as different, with a heavy leaning to the Diagnostic Statistical Manual, the International Classification of Diseases, still with us today. So some would say that this is still there and ever present. But my point here is what we do and know about language has a significant influence on tolerance. We use language in different ways, and we categorise and label individuals, not just those with disabilities. So at this point, I just want to turn to a nice quote from American civil rights activist Cesar Chavez, who captures this and demonstrates how we as society will use language that demonstrates our understanding of a given phenomena at a given time. Our language is the reflection of ourselves. A language is an exact reflection of the character and growth of its speakers. So now have we referred to people with learning disabilities over the last 100 years or so. and what actual terminologies have been attributed to a group of people with a diverse set of needs. And this leads me into another visual representing how over time people with learning disabilities have been referred to over probably the last sort of 100 years or so. So if we look at 19th and 20th century, in the advent of the 1930 Mental Deficiency Act, the term commonly referring to this group of people of learning disabilities, we know them now, are idiots, imbeciles, feeble-minded and moral defectives. And then we had the National Association for Parents of Backward Children. And then the terminology moved into the 1950s and 60s, the word educationally subnormal. And in fact, I can remember looking back in some documentary evidence and seeing the word childhood schizophrenia related to autism and autistic spectrum disorder as we know it now. And then in 1961, Enoch Powell, in a famous speech and movement within the Houses of Parliament, has made a statement to move and close long-stay institutions in 15 years. So in the 1970s and 80s, the 1971 White Paper for Better Service in Mentally Handicapped triggered that movement away from the long-stay hospital for this group of people. And in terms of terminology and language, in the 90s and the noughties, the learning disability, learning difficulties, intellectual disabilities, development disability. And if we look across the pond to America and the States, it's only a few years ago that in two states where the term mental retardation has been removed. So I'd like to just now reflect and pause for a moment, because I can remember having the privilege of working with a person with learning disability. And this allows me to briefly share her story with you. Heather is an able woman with a learning disability who I had the pleasure of working with on a number of occasions prior to the development of a chapter she wrote for me when I edited a book, Intellectual Disability and Social Inclusion, a critical review in 2009. So at that time, intellectual disability was just coming into usage. And I just wanted to share what she said to me when I asked her, well, how do you feel about this new term, intellectual disability? And Helen's thoughts on this, I felt, still stay with me today and are quite profound. It's normal to be different. No one is the same. We all have our little quirks. We have different opinions, which are often shaped and developed in 5 minutes. So I thought that was quite a good quote that has remained in my mind, and it reminds me of the social construction of language. And in this neurodiverse world we live in now, we have to ask ourselves, what is normal? So I now want to move the talk on a little and think about a key determinant of difference. And this is material disadvantage. And by that, I mean primarily income. So we can turn to many sources here to make this point in general. The Marmot report, evidence of those with disabilities living with a family with a disabled child, having a reduced life chances that impact across their whole life course. And of course, our own emerging understanding of who has been affected by COVID-19, those with pre-existing comorbidities and those from BAME groups are disproportionately affected by the virus. So I'll come on to what we know about COVID and people with learning disabilities in a moment towards the end of the talk. But in understanding why we consider people with learning disabilities as one of the most vulnerable within society, for me, we have to examine two key facts. Material disadvantage compounded by significant health conditions, that if we make with any comparison point with a non-disabled population group, people with learning disability are different and disadvantaged through no fault of their own. So I'm just going to put that into context and give you some backdrop to this. And I think it's relevant to state by referring to Professor Carl Claxton's work at the Centre for Health Economics at the University of York. And he starkly commented that over the last 10 to 12 years, austerity cuts to the NHS, public health and social care have killed thousands of people, more people in England than expected, according to his large study of its kind, the largest study of its kind. He goes on to discuss how restrictions on the growth in health and social care expenditure during austerity have been associated with tens of thousands more deaths than would have been observed had pre-austerity expenditure growth been sustained. The researchers in his study, who analysed the joint impact of cuts on healthcare, public health and social care since 2010 to 2015, found that even in just the following 4 years, the spending squeeze was linked with 57,550 more deaths than would have been expected. The findings, worse than previously thought, were revealed in the journal BMJ Open. And we already know, if we refer to people with learning disabilities, the life expectancy of people with learning disability is around 65 for men, 63 for women, compared to Office for National Statistics data, where non-disabled, the general population, men, it sits at 80, and non-disabled women, it sits at 83. So we know that the majority of people with learning disability who have a mild learning disability, and those people are more likely to be living in socially deprived areas. So that's a brief backdrop for any individual and family living in a socially deprived city, placed in what we refer to as quintile 1. But what do we know about how austerity and living in challenging neighbourhoods on a daily basis for people with learning disabilities from their own perspective? Well, at this point, I want to turn to some of the narrative from my own doctoral work, which I completed a number of years ago now, in July 2013, complemented by my practice experience of working in a large city in the West Midlands. And to do this, I'd like you to introduce you to 3 men with mild learning disability: Jack, Pete and Kevin, all pseudonyms to protect their anonymity, of course. They lived on their own in tough areas of Coventry, all described in postcodes categorised as quintile 1. These were men sitting on the margins of society, trying to get by as best they could. And in the 20 in-depth face-to-face interviews I carried out with the men, the majority had similar experiences to Jack, Pete and Kevin. Jack had a limited social network. His health was not too bad, but after his rent and most of his living costs, he was left with around £40 to live off. I asked him what having a reduced income meant to him on a daily basis. And the next slide represents a man who clearly needs to budget to have the basic things that me and you take for granted, such as a quilt on his bed. I'd like a new telly, made with some blinds, a room, a quilt on the bed. You just have to save. I have to be careful, you know. I have to pay my bus fare in the morning, swimming at night, and then I have a drink, and sometimes just one, or absolutely nothing at all. So I wanted to find out how this group of disabled men got by living in deprived areas. So Pete, with the next chap, lived with his partner, and similar to Jack, described the impact of having to live off very little. He too had around about £45 per week to get by on. So the next slide, like many in a similar situation, are forced to make choices that nutritionally would over time have a negative impact on their health. I interviewed Pete in his 3rd home in 5 years. He had to move for fear of threats to safety from others in his neighbourhood. And I asked him how he was getting on in the flat he was living in now. He recalls a constant threat and worry about being beaten up again. Well, just from the kids where I live now, but I still get that same feeling. I'm going to get hit by that bloke again. Oh, never that bloke, but I still get those feelings. What is it out there? What's going to do? Is he going to do it again? Yes, when they come round, I feel intimidated. Yes, what to go out and do? And are they outside? I just wait until they're gone. Yes, that is why my high blood pressure goes up and the doctor signed me off. So what was interesting about this quote is that he directly made the link between his social circumstances and where he lived and the impact on his physical health. Another man's story followed the same theme as a result of living in a challenging neighbourhood, forced to move from home and live in the sustained constant negative psychological impact on his health and well-being. The reason we moved from there is because we had those kids. They were shoving fireworks through the letterbox, stones and eggs at the doors, and urinating through the door. This lasted for about 7 years. My relations would never come and visit me. I had to go to them. I would never go out to the youths because I don't want to get my bloody head kicked in. By listening to these men, I was able to demonstrate how these three interconnecting social divisions, disability, gender, and inequalities, coincided to have an impact on this group of men's health and well-being. And we know from the development of empirical evidence over the last 3 to 4 decades, showing us how inclusive research methods can open up the opportunity to listen to people with learning disabilities. And there is great value in hearing their lived experience on a number of topics that touch their lives. So for me, what makes this group of people vulnerable is the socially constructed difference associated with learning disability, and an established evidence base demonstrating general and specific health conditions that impact on their daily functioning and lives. So we know the most recognisable and genetically known cause of learning disability, Down syndrome, and therefore we were aware of the organic health conditions associated with Down syndrome, such as atlantoaxial instability, the weakness in the neck that affects 10 to 15% of the population. And we know about the heart and lung defects. So this is an example, just to illustrate my point, as this talk is not about taking a clinical focus. I'm also sure many of you listening will be, in varying degrees, familiar with this evidence. Most causes of learning disability are unknown, and up to this point, I haven't made the reference to the impact of being a carer of a person with a learning disability. But it's worth at this point flagging up the brilliant science of genome sequencing that we are leading the world and the NHS has invested in. A couple of weeks ago, I heard on the radio for a lovely interview with a Professor Mark Caulfield at Queen's London. His brilliant work on genome sequencing and how rare genetic variants may explain their certain conditions, and he described the value of his work to parents of disabled children. He points to 80% of rare disorders having a genetic causation, and how families with children with rare conditions will painstakingly try to find a cause to explain the presentation of their disabled child. He described how one family he was involved with had 189,000 contact points with doctors and health professionals for their son. That is years of frustration. Professor Caulfield had discovered the Ren gene causing learning disability of their son, which in this case presented a great relief for the parents. So putting my practitioner hat on, I remember distinctly trying to help individuals and families navigate their way through and access different forms of help in our health and social care system. And indeed, learning disability nurses are absolutely great at doing this. I suppose my wider point here is the majority of learning disability is unknown, so we currently see the experience is different manifestations of difference and tolerance or intolerance to that difference. So now I want to move us on to the next section of my talk that brings us up to today, and perhaps no better place to focus on and how we understand COVID-19 impacting on people with learning disability. I know from chairing a virtual session we held at the Royal Society of Medicine in November 2020, where the eminent Dame Professor Sheila Hollins spoke. There were some mixed experiences being reported at that time from hospitals where every possible reasonable adjustment had been made to enable families and relatives to go onto units and wards where their son or daughter with learning disability had COVID, through to narratives where there were treatment failures, resulting in do not resuscitate being given to the patients with learning disability and COVID. Turning to the work done on this, here are some of the headlines as I see them. But I always put a bit of a caveat around statistical data and LD. As we know, work like this is drawn often from the Learning Disability Register, and we know that the register itself only captures around 25% of the population group. And given the varying terminology attributed to the population group, which I've already referred to, it makes it tricky to adjust for in studies. Some studies will also adjust for variables that, as I've highlighted earlier, such as deprivation, comorbidities, are more linked with those with mild learning disability. So in the leader report reported in 2021, there was 1,455 deaths since February 2020. We also know there's a higher prevalence of risk of mortality from COVID-19, diabetes, obesity, epilepsy and poverty, all significantly present within the learning disability population when you compare with the non-disabled population. We also know this is complicated further, where the health outcomes and access is poorer for people with learning disabilities. The learning is also that people with Down syndrome are at high risk. And also there's lack of clarity on the associated risks for people with mild learning disabilities. So I always find it helpful to turn to Professor Chris Hatton's work, and particularly his latest blogs, which I think are really great and insightful. And he looks at a different data set in a different way. So he looks at the peak age of death for people with learning disabilities from COVID-19 being around 55 to 64. So building on this, a paper published in the BMJ July 2021 by way of an editorial by Courtney and all, and then a follow-up study presented in the same journal by Elizabeth Williamson and colleagues, who was a biostatistician, which I'm now going to refer to. They set out to assess the association between learning disability and risk of hospital admission and death from COVID-19 in England among adults and children. And they did this by obtaining patient level data from 17 million registered with our general practice services. And then they linked that data with death data from the Office for National Statistics, drawing out data from the second wave of COVID. So it's pretty recent stuff. So of that data set and the children aged around about aged children and young people, they referred to and picked out those with 16 years and older. But they then compared this with the Learning Disability Register. And to put it short, they were looking at a sample of around 90,000, roughly working out about 0.63% of the population. And a general rule that we go with is around 2 to 3% of the population have a learning disability. So from their study, probably the most recent and authoritative one I can draw on, 538 of that study of that factor had COVID-related hospital deaths, 222 had COVID-related deaths, and 602 had non-COVID deaths from that population group. So as I've mentioned earlier, I like listening to Chris Hatton's work and certainly his blogs of recent times. So do tune into those if you don't already. I'm sure many of you do. So I'm going to turn to his sort of take on this now, and he drills into the data in a different way in terms of how social care data is accumulated, and he extrapolates from notifications of people's deaths from the leader programme, which is estimated to pick up 65% of deaths of people with learning disability. So he claims the figure is over 2,500 people with learning disabilities have died from COVID over the last year, not the earlier figure of 1,450. So no doubt, as we move into the spring next year, a clearer picture may emerge, but concluding out of what we know about COVID and learning disability, Down syndrome, cerebral palsy have a markedly increased risk of hospital admission and death from COVID-19. And like other population groups who have associated comorbidities, such as obesity, epilepsy, deprivation effects, can complicate the interpretation of this data as well. So this talk up to this point has taken quite a broad look at the population group as a whole. But it'd be remiss of me in trying to put forward a discussion on how we understand people with learning disability as vulnerable, without giving reference to the 2,070 individuals with learning disability and autism still detained under the Mental Health Act, and in many cases, without having committed a crime. So this takes us back to how I started the talk referring to holding people in institutions. So what do we think is the verdict on what is known as transforming care agenda? Or more importantly, why has it not had the impact it perhaps was designed to have at its inception? So to do this, we will briefly look at what the aspirations of transforming care, why only yesterday, the BBC's national news profiling Tony Hickmott's plight, I'm sure you all saw this, with the headline, 100 people with learning disabilities and autism in England have been held in specialist hospitals for at least 20 years. And yet in the case of Tony's, he was made fit for discharge by psychiatrists in 2014. So I will share my viewpoints drawn in part from acting as a clinical expert on the care treatment reviews, part of the Transforming Care programme led by NHS England, a vehicle to support earlier discharge of these detained individuals. And I was lucky enough to have this experience where I took annual leave to do these days over a 7-year period. And I finished this piece of work in December 2020, primarily for NHS England and CCG in the Black Country. So I'm drawing on that experience. In 2015, the government promised homes, not hospitals, when it launched its Transforming Care programme on the back of the BBC, uncovering the abuse at Winterbourne View Specialist Hospital near Bristol. Government ministers at the time pledged to reduce the number of deaths patients in such a hospital settings by 35% by March 2020, with the aim of people being brought back into their communities with tailored support packages. But by March, according to the BBC last year, there were only 300 fewer patients detained and a reduction of just 13%, not the 35% desired. So data from the NHS digital shows in March 2015, there were still 2,395 people detained. In March 25 years later, 2,095 still detained. And in October 2021, 2,070 still detained. So government policy, building the right support, which was launched in 2015 as part of the Transforming Care, a real positive nod to trying to develop bespoke packages of care close to people's homes, was great. But if we take a policy viewpoint, I'm afraid the lack of financial investment in community care, arguably in the preceding 40 years, has led us to this point. In short, why should we be surprised that this has happened when the complexity of finding ways of helping this group of people is fraught with different enactments of the Health or Social Care Act, varying joint commissioning arrangements across localities? Some, I should say, are really good at developing the partnership agreements necessary, particularly in the Northwest. The reduction in local services to be able to offer choice for that tailored package and the hands-on workforce across adult social care, trying their best, but being undervalued and underpaid. So why would they not go to Amazon or the local Aldi for work options? I remember being a community nurse. There was no local state hospital. So some way forced the community provision to develop its own assessment and community provision, some of which were really innovative and effective. Some resettlement programs for people with learning disabilities have been absolutely wonderful, really changing lives. But I cannot help feeling that the institutional baggage still casts and hangs over us. So what did I learn from being a clinical expert on many panels, working alongside commissioners, experts by experience, assessing the care packages of people in different detained settings? Well, there's a few things I'd like to share. When the panels were fully represented, i.e. a commissioner, a social worker, existing provider, multidisciplinary team were timetabled in, the relatives were contacted for their viewpoint, the patient with learning disabilities was consulted about the purpose of the CTR in advance, they could work really well. Early CTRs, 4 weeks on admission, enabled the discharge thinking to begin immediately, and the specifications to the provider, despite assessment period of section 3, could be begun. But I saw real variance in a person-centred planning approach, accuracy and comprehensiveness of documentation across service provision. Although on a case-by-case basis, variance in risk-taking behaviour across the multidisciplinary team altered the decision-making processes, perhaps from a reluctant psychiatrist, the RMO, not sure if what they offered could be reliably replicated in a given community setting, through to the willingness by MDTs to enact the discharge from the outset on admission. E.g., some patients on Section 3 admission for assessment under the Mental Health Act had that section for 5 to 7 years. Despite CCGs must have completed the assessment as a guiding regulating standard, within 12 to 15 weeks of admission. So in summary, for this group of people with learning disability and autism, the 2070 lingering and detained still seen as presenting with complex needs to the system, the heartache for relatives, the sadness, the disappointment and dissatisfaction for all those invested in this system stems from failures of the past being borne out today. I should say, perhaps on a more positive note, that the spotlight on learning disability and emphasis given within the NHS plan and the health improvement plan and the recurrent news stories for people, the profile of this group of people, for me, in my career today, has never actually been higher. The advancements of neuroscience are seen as progressing us an understanding of difference. So by way of conclusion to the talk, I would like to hand it over to the questions time. And I think Nikki may come in. I think one of the next, there we go, the next slide there is, I don't know how we're doing for time.
We have about 20 minutes if we need it.
Perfect. Okay.
So if anyone does have any questions they'd like to drop into the Q&A, please do so now.
Shall I stop sharing? Do you want me to leave that there?
However you prefer to do it, Martin, I think. But that's
look.
been really eye-opening for my own personal perspective as an educator. It's really relevant to me.
Okay. Right, that's good to hear. In what way?
Just really, obviously, I've dealt with learning disabilities throughout my career as an educator, but it's interesting to see. I mean, especially how COVID has had a knock-on effect, and no, it's I'm sure it's relevant to lots and lots of disciplines, really.
How are we doing then?
Okay, so we haven't had any questions come in yet, so shall we go with what you have planned?
Yeah.
And then if anyone else wants to drop something in as we go along, maybe we can insert that. Is that all right with yourself?
Yeah, that's absolutely fine.
Okay, great stuff. So if you'd like me to read these out for you, the first one would be, do you think we understand people with learning disability better now? Do you think we are more tolerant? What is within your gift to improve this, and how?
If anyone would like to be brave and just turn the camera on and share, that'd be great as well, if they have that option. Nikki?
Westwood says, Martin, how can we make a real difference?
Okay, that's a great question. Really broad question. I mean, I'd say in your case, Lynn, carry on doing what you're doing. Lynn, for those that don't know, has been an avid advocate for people with learning disabilities in many different ways, primarily as a course director for a learning disability at the University of Wolverhampton, but also very active within sharing understanding of learning disability. So I think on an individual level, I think we can all make a difference. So I've just mentioned how I think Lynn in her career has made a great difference. I suppose there's different ways I look at this. There's choose the battles that you can actually win, and that within your gift, within whatever capacity you've got. I think the other thing that we need to do, similar to other social divisions in society, where I refer to myself as a white middle-class male, if I hear another man, boy, being disrespectful to women, I should shout that out. So I think that responsibility sits with that individual. So if we move that then to disability, if we hear young people, or if we hear people being disrespectful, because I think that's how, at a very subtle level, you can start to check and build tolerance. And if we all did that, and we all did that collectively, then you might just start to see some difference. But I mean, I should say, I think from my work that there is more tolerance towards this group of people. When I sort of came into the field, I know from my own, I've got 3 children, I know the way that they perhaps refer and tolerate, and have come back from school and talked about a child with cerebral palsy in their class, and how they sort of value that diversity, and how that individual overcomes the adversity associated with that. I think it's great. I know that language is great. But I suppose it depends on whatever role you're in, really. I do just have to be sensible in saying what could we do different. Is that, you know, the reality check is here that this is still a very misunderstood group of people. Often the services within the NHS that are provided are massively underfunded, still referred to as Cinderella services. And what we have here in the sort of, we look across adult social care, which has about 14-15 billion in its budget to provide social care. It's a big provision, learning disability or learning difficulty within social care. What we have is a real challenge there in terms of attracting the workforce. And this isn't just related to learning disabilities, this is adult social care. And if we think about 75% of the hands-on care delivery is done by someone that we would see as not maybe having a formal qualification, we can, and perhaps services that may be challenged by different systems and structures and leadership. You know, perhaps we should not be too surprised that we hear the revelations that we hear from Death by Indifference, Winterbourne, because those of us in the field always, when we hear that, sense check ourselves and think it's probably just the tip of the iceberg. And that's really saddens me to really say that. But I think you have to accept that people with learning disabilities are incredibly vulnerable. We know that. But alongside vulnerability is innately discrimination and abuse. So I think if you take that as a sad but realistic starting point, then if you build out from that, you start to think about championing the cause. You start to think about your own self and reflect on your own self and how you behave in all sorts of ways, use of language, which I've obviously touched on tonight. And you start to really try and change yourself in terms of how you interact, which hopefully may be a role model for other people. So I hope that sort of answers your question, Lynn.
We have a couple of comments that have come in off the back of that. Lisa says, COVID-19 did highlight inequalities. I felt outraged sometimes how those with underlying health conditions were viewed as somehow less important than some. And then a further comment is, the data for COVID-19 is worrying. Martin, do we think we can use this to hopefully turn the understanding of people with a learning disability around and increase their value in society?
Yeah, I think I'll take both of those together actually, because they're both touching on the same theme. I think we need to get this moving ourselves, you know, and that's part of my ambition for 2 of these talks, is that we get people with learning disabilities in to share their story maybe in spring next year, but also we start tweeting about this. This is the story of that came out yesterday. We should be outraged at this as a society. We shouldn't tolerate it. And you know, it's only through standing up yourself and pushing the dialogue of change that you may look back in time and see it, which is, I think, is your question, that this is a pinpoint of change. Yeah. So I know when we heard Death by Indifference and getting it right, I worked really hard with the Royal Colleges to try and develop a Getting It Right tool, because we were aware of the really poor journeys that people with learning disabilities are having in and out of acute care. So I'm a pragmatic nurse. I want to do something about that. And I was in a position to draw 4 lots of funding from the Royal Colleges. And MENCAP then commissioned a really nice Getting It Right tool, which went out to, we developed 4,000 of those. I'm not exactly sure how many hospitals they landed on and what they did with it, but the work was to develop that. So I don't know what's going to happen as a result of this. There's lots of people being affected by COVID. But I think what it does throw a spotlight on, and I think is your real point, is that will the obvious disadvantage of the experience of people with learning disability, as we understand it through the COVID data as it comes through, who will pick that up and champion it? I think that's your question. I think we all can do that if we're in the field. You know, I've just picked out some studies from researchers, and no doubt there'll be more research that will come out in the spring, and that's great that we've got that. But you know, how it triggers change, well, time will tell. I'm hopeful that the wider learning as we come out of COVID, and the points I was making about, come on, it's those again with socially deprived backgrounds, BAME groups, already living in our quintile 1. I can't help being political. Well, you know, you put a pandemic on the end of 12 or 10 years of austerity. What do we expect? So I do hope it's a pinpoint of change. But, you know, none of us have got a crystal ball. But I think, coming back to my point, then it's what change can you make yourself? If you're in the field, you have a responsibility to do that. If you're training as a nurse to do that, you have a responsibility to look at that for yourself. And I'm a great believer in networks. So social media presents a network. It presents a network and a voice. It's just galvanizing that voice in a responsible, thematic way. And I'm sort of looking at Lynn, my colleague here, to sort of help me with that. And I'm sure she'll be tweeting this afterwards and sharing it, and that's great. So change can start from small things. We all know that. But you know, this we don't want the lessons learned from being a pandemic, which only come every 100 years or so, to just rest there. So I think the wider learning is not just about disability. The wider learning is about tolerance of everybody. So that would be my little message for you.
So that's a very, very fair comment. We've not had any more questions come in, Martin. So is there anything that you? Oh, we do. We've got one come into the other box, the chat box. John says, has the number of people with autism increased over recent years?
Oh, that's a really good question, John. This just takes me back to when I was in a community team I worked, and when, you know, I come from a social scientist, sociological background on this, I have to say, and it does concern me, the fads of terminologies and categories of people over time, as you probably picked up from a talk. And I'm going to share a story with you about working with a family for a bit of time, which I hope illustrates the point and where I'm coming from. So I don't know the still known cause. There's lots of reasons, but I think let's forget about the label. Let's just value the diversity and look to adapt reasonable adjustments to those for those people. So I can remember working with a family in a community, and they were fighting the headmaster of a special school for quite a while to want to get on what I thought was the bandwagon of autism and autistic disorders at the time. And I remember visiting the family and visiting the mum and visiting the dad, and they got to a point where they got a private assessment in a unit in Birmingham, where they had their two-way mirror. They were interviewed, and they came around with their assessment, and you know, they got the label of autism. And I went to do the follow-up visit with the two, the mum and the dad. I sat in the front room, and I said, okay, so this must be, where are you sitting with this now? And I looked at the mum, and she was animated. She was really pleased. She was thinking, she was a sense of relief. She had this label attached to the difference that she presented with this child over bringing the child up. And then I looked at the dad, and the dad went, well, you know, what does it mean? You know, I don't understand it. And is it going to make any difference to him? So that little bit, does it make any difference, and really resonates with me. So you have the two spectrums of what a diagnosis can do in that one moment for me. Relief for a parent who wants some explanation, and that's absolutely justified. To, okay, so I've got this. It's not going to make any difference to him. He doesn't understand it. This is his dad. You know, and what we're going to do about it. And at that time, you know, the services and understanding, coming back to your point of your question, is to, you know, anything better. Well, we probably do in terms of maybe skilled, more reasonable adjustments and skilled and research work that's done there. Does that actually make a difference to the individual? I don't know. I don't know. You'd have to ask them. You know, but you know, for me, we hear some great stories of people with different diagnoses on the autistic spectrum, and it's actually a gift. You know, I heard a professor talk the other day who was talking about their difficulty, and they saw it as a real gift. It enabled them to focus on data, it enables them to drill down where it was perceived by society as something different. They saw it as an absolute great asset to them because it enabled them to do their job better. Yeah. So I don't know, I've waffled a bit there. I don't know if that answers your question. So I don't know. I'm pretty ambivalent, as you can probably hear. I'm pretty ambivalent, and I'm minded by one of the other talks we did at the Royal Society of Medicine. And bear in mind the majority of people within the intellectual disability section at the Royal Society of Medicine are psychiatrists. Which, okay, so when I was chair there, we hosted this talk, and it started to question the value of the Mental Health Act. And this is psychiatrists talking about this, and it was really, really insightful. So what value does that actually do? And if we look at what's happening with the people still detained, the problem is it's not enacted. And there's a number of reasons why that. This is probably moving to another lecture, and it takes me back to the CTR experience I had and my learning from that. If you've got a section of Mental Health Act, let's take 3, where you should be no longer in a place according to this Mental Health Act after 3 months. So we've got people in there 6, 7 years, 8 years, 9 years on, and you've got the individual just reported on yesterday who was fit for discharge in 2014, and he's still there 7 years, 8 years on. There's something wrong with that system. There's something wrong with the way that we look at this group of people. So I'm just reflecting on that in the moment, really. And I think, again, coming from a sort of social science perspective, we have to ask ourselves, how valuable are the DSM and ICDs? And I'm sure psychiatrists are very skilled people, and in terms of their clinical formulation, they don't just look at that, they look at a wealth of other things, professional intuition. But you know, I'm a little bit unsure about where we are, and I think until you change the way that powerful people diagnose and make decisions on people's lives, till that's changed, you have to then question, where's the movement? Yeah, I hope that makes sense.
That's there's been some really fascinating perspectives there, Martin. I've really enjoyed your talk. I'd just like to thank you really for this evening and say that I really look forward to the follow up to this talk.
Great. Okay, well, thank you very much. I think we run out in an hour, don't we? We only have an hour with these Zooms anyway, so it'll stop me talking. Well, thank you. I'd just like to say thank you very much for those that have attended. You've given me a chance to sort of share, which is nice. It's a real privilege, and I hope you've got something from it. And let's continue the dialogue. Let's turn to the Twitter and start talking that and set up the next one in spring.
Lisa says, thank you very much. I found this really interesting.
Thank you, Lisa. Thank you very much for your support, Nikki. Great. Okay. Cheerio. Bye.
Bye.